There's been the phenomenon of pseudoprogression, Mark.
Yeah, where I think I was most convinced of this in melanoma, where you saw these initial flares, and you can imagine that with immune therapy and effector cells that might cause a radiographic abnormality to actually increase in size, but yet over time you see regression of this lesion. So we have this category of immune-related responses and that sort of thing. So it
certainly complicates our normal assessment of response. I mean,
but in general, these
criteria, standard resist fly out the window.
But in general, these patients feel better because they're really in the process of reducing their volume of disease, and so I think it's a little bit different than patients who are truly refractory and progression because they, have worsened disease-related symptoms, whereas these immune-related patients may not necessarily behave like that.
So if they're having worsening symptoms and radiographic progression, chances are it's not going to be pseudoprogression. Right. Any other comments or thoughts, Alice?
I'll just mention that this is such an active therapy, in my opinion, that in this lung cancer master protocol we're developing, where we're using a foundation medicine platform to determine mutations and place patients on one of 4 or 5 different arms.
In squamous cell.
In squamous cell. For the 40 or 50% who don't have a marker, we've made the arm immunotherapy. Because I think in a squamous cell patient with no other options, I think immunotherapy is a good bet.
And the early reports suggested higher activity in squamous, although as time has gone on, it seems to be pretty equivalent.
I don't think it's higher. I think there is activity, which is something, and there is activity in squamous patients. Mostly all of them have smoked, so there is activity in that group of patients. But I think it's hard to say one versus the other. It's interesting. Someone who's never smoked, who might just have an EGFR mutation or an ALK rearrangement, maybe they don't have the mutation burden, and perhaps that might be why some of the.
What about the notion of introducing these agents into the curable setting, frontline, adjuvant, or locally advanced?
All of the above. We discussed it at a recent SWOG meeting, and certainly it helps to have proven activity in the advanced setting first, but I think this is the perfect maintenance drug. Again, if the toxicity is acceptable, and I think it will be, this could be a great way of doing maintenance, and even in stage 3 disease, maintenance of some sort.
And that's been proposed by the Energy Committee, although I understand CTEP is not too enthused.
I think every group's going to want to do this, and I think they should. This is going to be, and there are all these challenges. How do you sequence with chemotherapy? How do you sequence with targeted therapy? And the preclinical models for this are few and far between, because most of the immune mice that we use, really aren't good settings for testing immunotherapy. So you need very special models here.
In locally advanced disease, when we give chemoradiation, we'll often see a fair amount of pneumonitis, which we generally treat with steroids. So, Govardhan or Mark, what are your concerns there in terms of how to manage it, particularly if we do use a maintenance strategy?
Well, it's a concern. There is, this background concern of pneumonitis with some of these agents, and so you would need to be concerned about that. The concern about our normal treatment for significant radiation pneumonitis is high-dose steroids. Roy mentioned it's not clear that that really impedes the activity of this class of drugs, but it would be a concern in that population.
So what might be theoretically inferior has never really been borne out, at least in advanced disease.
Right, yeah. But you're trying to activate T cells, so that's why all these antibodies, by the way, that we use lack ADCC. There's been so much effort to show they lack that, because you want to block the interaction but not kill the very T cells that you want to fight the tumor. So yeah, I think steroids on long-term steroid use, or getting the patient in 4th line, and that's very interesting to me. A lot of the trials that were done, now there are 3rd-line trials ongoing. It'll be interesting to see if those response rates are as high as when earlier stage patients were treated.